Hello, everyone, and welcome to our second module on meningitis. In the first video on meningitis, I finished with this slide, which shows the different pathologic causes of meningitis and also the empiric antibiotic treatments that we use when we're treating meningitis, but we don't yet know which bacteria or virus is involved. What I'm going to do in the rest of this video is go through some of the specific pathogens listed on this slide because they each have unique features that you need to be familiar with. So we'll start by talking about Streptococcus pneumoniae, which is the most common cause of meningitis in all age groups. This is the classic cause of bacterial meningitis, and it usually leads to the most severe symptoms. It was named pneumoniae because it was initially described as causing lung infections, but as you may know, strep pneumoniae can cause lots of infections in places outside the lungs, including in the meninges. Strep pneumoniae are lancet-shaped gram-positive cocci that form in pairs. This is a picture of what they can look like. And this can lead to meningitis following a strep respiratory infection. So one historical clue in a patient with meningitis that they may have a strep pneumonia infection in their meninges is if they tell you that recently they had a respiratory infection as well. Some of the things that increase the risk for developing meningitis from strep pneumoniae are listed here. So patients who don't have a spleen, whether that's functionally they lack a spleen because of sickle cell disease or whether they've actually had a splenectomy for some reason, those patients are at higher risk of strep pneumoniae meningitis, and that's because strep pneumoniae is encapsulated, and the spleen helps to protect against encapsulated bacterial infections. Also, alcohol use has been well described, heavy alcohol use, as increasing the risk of developing strep pneumonia infections. And then, as I mentioned, strep pneumoniae causes lots of infections outside the meninges. It causes otitis media in children, it causes pneumonia, it causes sinusitis, and it can cause other infections as well. So when you do clinical rotations in the emergency room and you identify patients who have bacterial meningitis, they will be treated with antibiotics, just like we saw on the first slide in this video, but they will also often be treated with dexamethasone. So let's talk about why we do this. So dexamethasone is a corticosteroid and it suppresses meningeal inflammation. And there have been some studies showing that if you give this to patients with bacterial meningitis, it reduces the rate of serious complications of meningitis like hearing loss and other permanent neurologic deficits. Now, the studies that show that dexamethasone is beneficial have shown that it's only beneficial in cases of strep pneumoniae. But when patients first come into the emergency room, we often don't know what the bacteria is yet. So in many cases, they're given dexamethasone empirically, and then it can be stopped later once you identify the specific bacteria if you find out that it's not Streptococcus pneumoniae. But remember what I said, strep pneumoniae is famous for causing the most severe symptoms and clinical features of meningitis. And so that's why dexamethasone has a benefit in patients who have meningitis from this pathogen. Okay, moving on, our next cause of bacterial meningitis is Neisseria meningitidis. So Neisseria meningitidis are gram-negative cocci in pairs. They are diplococci. This is a picture of what they can look like here on the slide. And I talk about the gram stain and cocci and rod forms of bacteria and all those things in detail in videos in the ID section. Neisseria meningitidis is transmitted by respiratory droplets. You inhale the droplets and the bacteria enters the pharynx and then it goes to the bloodstream and then it can travel to the cerebrospinal fluid and cause meningitis. One thing to know about Neisseria meningitidis is that there are many asymptomatic carriers. Some studies have shown as many as 10 to 20% of young healthy people can carry Neisseria in their pharynx without being symptomatic. But then if those people spread the bacteria to someone else whose immune system isn't able to contain the bacteria, that can lead to infection. Neisseria meningitidis has a polysaccharide capsule that helps prevent phagocytosis by white blood cells. And a super high-yield thing to know about this bacteria is that it has a structure on its outer membrane called lipo-oligosaccharide, or LOS. This is a bacterial endotoxin, and I talk about endotoxins versus exotoxins in the ID section, and it has many toxic effects on the body. It's similar to LPS, which is another toxin found on many gram-negative rods. And so the LOS is what activates a severe inflammatory response, and that leads to many of the clinical features of Neisseria meningitidis infection. So there are a couple of sort of classic complications of Neisseria meningitidis when it causes meningitis that you should be aware of. So first of all, patients who have meningitis are going to have Neisseria in their bloodstream. They have bacteremia, and that's because the bacteria travels through the bloodstream to get to the meninges. So they usually have meningococcemia. This means that you can culture Neisseria from blood samples. And they usually have features of sepsis, things like fevers, chills, and tachycardia. Beyond this, the LOS that I talked about in the last slide, remember that it's highly toxic. And one of the things it likes to do is cause bleeding and also cause thrombosis. So patients with Neisseria meningitidis infection can develop a purpuric rash. This is a picture of what it looks like here. This is from red cells leaking out of capillaries triggered by that LOS. They can also develop disseminated intravascular coagulation. And then rarely, patients who have Neisseria meningitidis infection can develop adrenal hemorrhage. In other words, they're developing bleeding from the LOS into their adrenal glands, and this can destroy their adrenal glands and lead to hypercortisolism. This is called the Waterhouse-Friderichsen syndrome. It's very rare, commonly comes up on board exams, and the underlying cause is the Neisseria bacteria causing hemorrhage into the adrenal glands. And all of these things listed here are big parts of the reason why Neisseria infection can be life-threatening. You should also know that Neisseria meningitidis can cause outbreaks, especially in places where young, healthy people live close together, so college dorms or military barracks. The reason this happens is, remember what I said before, that many people are asymptomatic carriers. And when you have crowded settings, you will get more asymptomatic carriers because people are spreading it around through respiratory droplets. And some of those people who pick up the bacteria by respiratory droplets can become sick with meningitis and sepsis symptoms. You should also know that the classic demographic to be infected by this bacteria is young, healthy people. So it often affects college students living in dorms and, as I said, healthy soldiers who live in military barracks. When you have a patient infected by Neisseria meningitidis, that patient needs to be placed on droplet precautions. These are special precautions inside the hospital to prevent spread of the bacteria. And I talk about all the different types of precautions in the videos on quality and safety. And then finally, when someone does come down with a case of meningitis, for example, a college student, close contacts who may have been exposed usually are treated with antibiotics for a brief period of time as prophylaxis so that they don't develop meningitis. Okay, moving on, our next cause of bacterial meningitis is Haemophilus influenzae. Haemophilus influenzae are small gram-negative rods. They are coccobacilli. This is a picture of what they can look like on the slide here. They also enter the pharynx, and then they go through the lymphatics, and from there they spread to the cerebrospinal fluid. So you won't see much meningitis these days caused by Haemophilus influenzae, and that's because there is a vaccine. So H-flu comes in different subtypes, and the types that have a capsule are called typable H-flu. And there is a subtype of capsular H. influenzae called H. influenzae type B. It has a capsule, and this used to be one of the most common causes of bacterial meningitis, but we now give conjugated vaccines in infancy, and so nowadays you almost always see meningitis due to H-flu only among unimmunized children. You will rarely see it among children who are up to date on their immunizations. Okay, so that's a nice segue into talking about encapsulated organisms. So most of the bacterial causes of meningitis are encapsulated bacteria. So for example, we just talked about how forms of H. influenzae that are typable have a capsule, and those are the forms that cause bacterial meningitis. Neisseria and strep pneumoniae are also encapsulated organisms, and it's that capsule that protects them from phagocytosis of white blood cells, and that's how they get into the meninges and cause meningitis. This also means that the risk of meningitis from all these encapsulated organisms is increased in special clinical situations, like patients who lack a spleen or patients with complement deficiency. In all of these groups here, the risk is so high that they need to be vaccinated against these bacteria, and we do have vaccines for these bacteria. And anytime you see a patient who lacks a spleen or has complement deficiency and they develop possible symptoms of sepsis or meningitis, they need aggressive early antibiotic treatment because they're at risk for severe infection from these encapsulated organisms. Okay, moving on, our next cause of bacterial meningitis is Listeria monocytogenes. This is a gram-positive rod, and it's a facultative intracellular organism, so it can live inside of human cells. It does not have a polysaccharide capsule like the bacteria on the last slide, and that's why it less commonly causes infection than some of those more virulent bacteria who have true polysaccharide capsules. The thing to know about Listeria is that it multiplies inside of cells when there is poor cell-mediated immunity for some reason. So Listeria more commonly affects older adults over the age of 60. It also can affect newborn babies. It can infect HIV patients. Organ transplant patients have to take immunosuppressant drugs so they can develop Listeria infection. Then Listeria is sort of famous for sometimes causing infection during pregnancy, which is a relatively immunocompromised state. The way that adults usually contract Listeria infection is from contaminated food, especially undercooked meat or unwashed vegetables or unpasteurized cheese or milk. This bacteria likes cold temperatures, and that's why undercooked meat is a common cause. And then in newborn babies, the way the infection is contracted is different. It's usually either via transplacental or vaginal transmission from mother to baby. Listeria has some special CSF findings you need to be aware of when you do a lumbar puncture in a patient who has meningitis from this bacteria. So first of all, the CSF in Listeria infection is famous for showing only mild abnormalities. So the white blood cell count may be in the range of 100 to 500 versus greater than 1,000, like you can see in Neisseria or strep pneumonia infections. Also, the glucose, which can get very low in bacterial meningitis, may be only mildly reduced in Listeria infection, or sometimes it's even normal. You should also know that traditionally we say bacterial meningitis causes the neutrophil count to go up in the CSF. That can happen with Listeria infection, but also sometimes it's the lymphocytes that go up. Listeria is one of the few non-tuberculosis bacteria that can drive up the lymphocyte count in the CSF. So in a patient who has a lumbar puncture and has Listeria bacterial meningitis, you can see an increased white blood cell count that can be made up of neutrophils, but it also sometimes can be lymphocytes, or sometimes it can be a mixture. You should also know that the gram stain of the CSF in Listeria meningitis can be negative. That's because it's an intracellular pathogen. It's also very small, and the bacterial load tends to be low. This is not a highly virulent bacteria, so there often aren't a lot of bacteria present in the CSF. Okay, moving on, our next cause of bacterial meningitis is group B streptococcus, also known as strep agalactae. These bacteria are gram-positive cocci in chains. This is a picture of what they can look like here on the slide. And this is the most common cause of meningitis in newborn babies. It's transmitted from mother to baby through the birth canal when the baby is born vaginally. And we prevent this form of meningitis in babies by giving ampicillin to mothers prior to or during labor so that they don't pass on group B strep to their baby. So one thing to know about meningitis in newborn babies is that they usually don't have classic symptoms. So a baby can't tell you that it has a headache or that it has photophobia and the bright lights bother it. Instead, you'll see generalized features of the baby not doing well, things like hypotonia of the muscles, weak sucking reflex. The baby can demonstrate poor feeding. Also, because of the inflammation involving the meninges, you can get increased intracranial pressure, so you can see bulging fontanelles. You can sometimes see sunken eyeballs as well. Now, meningitis from this bacteria has decreased dramatically because we check mothers for colonization with group B strep, and we give them antibiotics prior to labor if they have this bacteria. So the incidence of early onset group B strep meningitis in newborn babies, this refers to meningitis in the first 7 days of life, is way down, and that's because of maternal screening and prophylaxis. What's interesting is the incidence of late onset group B strep, which is from 7 days after birth to 90 days of life, has not gone down. And that's because the babies who contract group B strep meningitis in this time frame are getting group B strep from their environment after the prophylaxis given to the mother has had no effect. So they're picking it up from somewhere out in the environment, not from the mother, and the antibiotic prophylaxis given to the mother doesn't protect against this late onset form of group B strep meningitis. Okay, and then our final bacterial cause of meningitis we'll talk about in this video is E. coli. It's the second most common cause of meningitis in neonates. E. coli are motile gram-negative bacilli, or rods. This is a picture of what they look like here on the slide. And it's super high yield to know for your exams that the forms of E. coli that cause serious disease like meningitis are encapsulated forms that have the K1 capsular antigen. The K1 antigen is an antigen found on the capsule of these bacteria, and it inhibits complement activity and other immune responses, and it allows the bacteria to evade host response. And this K1 capsular antigen is almost always going to be present on any E. coli bacteria that causes serious disease like meningitis. You also always want to remember that E. coli has some special ways that we culture it in the lab. It grows on blood agar, MacConkey agar, and eosin methylene blue agar. And I talk about all the different ways we culture bacteria in much more detail in the infectious disease section. Okay, moving on, let's talk about viral meningitis. So the old name for viral meningitis was aseptic meningitis, and you'll still sometimes hear people use this term. The reason it was called aseptic meningitis is because you had clinical evidence of meningitis, but there were no bacteria identified in the cerebrospinal fluid, so it was called aseptic. We now know that these forms of meningitis are usually caused by viruses. And it's super high yield to remember for your board exams that the viruses that cause viral meningitis are almost always enteroviruses. So some examples of enteroviruses are Coxsackie virus, a super common cause of viral meningitis, also echovirus, also poliovirus. All of these are non-enveloped, single-stranded, positive-sense RNA viruses, and they're called enteroviruses because they replicate in the gut, even though this is a confusing name because they often cause disease in distant organs outside the gut, especially the central nervous system, including the meninges. All of the enteroviruses are transmitted fecal-orally. They usually cause a self-limited infection, and usually the only treatment is supportive care. There's no specific treatment given against the virus in most cases. Patients will recover from this in a few days, sort of similar to recovering from an upper respiratory infection from a virus. There is one special virus you should be familiar with in terms of viral meningitis, and that's herpes simplex virus, which we talk about in great detail in the infectious disease section, but let's review this briefly here. So herpes simplex virus comes in two important forms. HSV1 is what causes oral herpes, which is vesicular eruptions around the mouth. This is also the form that causes eye infections like keratoconjunctivitis. It can also cause encephalitis, which we'll talk about in just a few slides. Herpes simplex 1 loves to infect the temporal lobe of the brain and cause encephalitis. HSV2, on the other hand, is the sexually transmitted form of herpes simplex virus infection. It causes genital herpes. And among patients who have genital herpes lesions, up to a third of those patients also have meningitis symptoms and infection in their meninges. And then if you flip this around and you identify patients who have meningitis from HSV2, up to 85%, almost all of those patients have previously had genital lesions. So the genital infection and the meningitis go together. If you have genital lesions, there's a small chance, about a third, that you could have meningitis. And if you have meningitis from HSV2, there's a very high chance that you have currently or previously had genital herpes. And this form of viral meningitis is treatable. We use drugs like acyclovir, valacyclovir, or famciclovir, and I talk about all these drugs in detail in the ID section. So basically, the way that you work up viral meningitis is the patient presents with clinical features of meningitis. At first, you don't know whether it's viral or bacterial, so you do a lumbar puncture. And then the CSF, if it shows findings of viral meningitis, which means mostly lymphocytes, then you usually suspect the patient has viral meningitis. And at that point, usually no specific virus testing is done, except in special circumstances. If you think the patient might have HIV causing viral meningitis, then you can do blood testing for HIV, RNA, and antibodies. And then if you have a reason to suspect the patient could have herpes simplex virus infection, for example, if they're sexually active and have genital lesions, then you can sometimes give anti-HSV viral drugs. But beyond testing for HIV and HSV, other viruses are usually only tested for in very special circumstances. This is not something that's done routinely. And this makes viral meningitis different from bacterial meningitis. In bacterial meningitis, we almost always want to identify the exact cause, the exact bacteria, and know what antibiotics it is sensitive to. Let's talk briefly about encephalitis, which refers to inflammation of brain tissue. So when patients develop meningitis and inflammation of the meninges, remember that the meninges sit on top of the brain. So in some cases, that meningitis can spread and involve the brain tissue itself, and then the patient has encephalitis. So anytime you're evaluating a patient with meningitis symptoms, you want to make sure they don't have other symptoms that suggest that they have encephalitis as well. And I've listed some of these symptoms here. So these are things like altered mental status, motor sensory deficits, changes in behavior or personality, or speech or movement disorders. Basically, if any of these things are present, then you have to worry that the meningitis has spread and now has caused encephalitis. And if you do have evidence of encephalitis, if these things on this slide are present, then one of the first viruses you want to think of is HSV1. This is a very common cause of encephalitis. It's so common that when patients have evidence of encephalitis, antiviral therapy is usually given immediately. It's usually IV acyclovir because HSV1 is presumed to be the cause. And then remember what I said earlier, HSV1 loves to infect the temporal lobes. So they may ask about this on your board exams. They're going to want you to know that this virus has a predilection for the temporal lobes. And if you look at this image on the slide, it shows white here, which is evidence of inflammation involving the temporal lobe, sort of a classic finding in a patient who has HSV1 encephalitis. Now, HSV1 is not the only pathogen that can cause encephalitis. I've listed some of the other potential pathogens on this slide. Most of them are very rare. One thing to be aware of is that most cases of encephalitis are viral. Viral infection of the central nervous system can cause meningitis or encephalitis or both. Bacterial infections much less commonly involve inflammation of brain tissue. So as I said, the big virus that you want to remember for causing encephalitis is HSV1, but some others are listed here. So varicella can do this. Any of the enteroviruses we mentioned earlier can do this. And then there's a bunch of super rare causes I've listed here. I talk about all these pathogens in videos in the ID section, but they can potentially cause encephalitis as well. Okay, our last topic for this video is a brain abscess. So an abscess is a walled-off collection of bacteria and pus and white blood cells. And when that develops in the brain, we obviously call that a brain abscess. When there is a brain abscess, it usually has a bacterial cause, and the most common pathogens are Staph aureus and Viridans strep. When these pathogens spread to the brain and cause an abscess, what you will see on imaging is a ring-enhancing lesion. So this means that a bright ring of tissue surrounds the abscess after you administer contrast for the imaging study. The reason this happens is because the capsule surrounding the abscess is vascular and it's inflamed and it takes up contrast, but the core of the abscess, which has a lot of necrotic white blood cells and bacteria, does not take up contrast. And so these things give you a ring-enhancing lesion. This is an example of what one can look like here. There are other causes of ring-enhancing lesions besides brain abscesses. This is a big topic beyond the scope of step 1, but you should know that a brain abscess can cause this finding shown on this slide. So some patients have multiple brain abscesses, and this usually occurs when there's hematogenous dissemination of bacteria. So you have a distant site of bacterial inflammation, it spreads via the bloodstream, and it starts growing in multiple spots in the brain, and you get multiple abscesses in the brain. In contrast, when you see a single abscess, this is often from contiguous spread from infection of some structure near the brain itself. So for example, if you don't treat otitis media in kids or mastoiditis in children, those bacteria can spread to the nearby temporal lobe and cerebellum, and you can see a brain abscess in this region here. If someone has a dental infection that's poorly treated, that infection can spread to the frontal lobe because the frontal lobe is very close to the mouth. Same is true of sinusitis. The sinuses are close to the frontal lobe, so you can get a frontal lobe abscess from a sinusitis infection. And then lastly, you want to remember that toxoplasma can reactivate in patients with advanced HIV and AIDS, and this can lead to multiple ring-enhancing lesions that look similar to brain abscesses. I talk about toxoplasma in detail in the ID section, but it's a pathogen that when we're exposed to, if we have a healthy immune system, it will become latent in our central nervous system and it won't cause any problems whatsoever. However, if we become severely immunocompromised, for example, from HIV/AIDS, then it can reactivate. And what you get is growth of toxoplasma in multiple places within the brain, and that leads to multiple ring-enhancing lesions. And that concludes our second module on meningitis.